In 2018, I felt the need of having a society dedicated to the study of minimally invasive treatment applied to the thyroid. I realized that in Europe there were endocrinologists, surgeons, nuclear physicians, interventional radiologists, each one talking to their own specialty group, very limited interconnection. That group was founded with the main aim of having a multidisciplinary group of different people participating. I think we are working quite well in trying to put people together, trying to promote science, evidence, training course, fully dedicated to minimally invasive treatment of the thyroid.
Welcome to Save Your Thyroid, a podcast all about thyroid nodules. My name is Jennifer Holcomb, and I advocate for fellow patients suffering with this very common condition. Thyroid nodules impact 70% of adults in their lifetime, and the standard of care is surgical removal of half or all of the gland. But in recent years, safe and effective non-surgical treatment options have become available. In this podcast, I sit down with patients and physicians to discuss life with thyroid nodules, treatment options, and how to save the thyroid whenever possible. Today's guest is Dr. Giovanni Mauri, an interventional radiologist at the European Institute of Oncology, where his practice is dedicated to minimally invasive treatments in oncologic patients. In 2018, he founded the Minimally Invasive Treatment of Thyroid group, and in 2021, he led the European group of authors in writing the European guidelines for thermal ablation in patients with thyroid tumors. Dr. Mauri will be the local host for an upcoming course on thyroid thermal ablation, which is the first European course on this topic. He is the author of 170 scientific articles and has presented at more than 200 national and international congresses. In today's discussion, we'll learn more about interventional radiology, treating thyroid nodules and cancer, and training physicians in thermal ablation techniques. Dr. Mauri, welcome to the podcast.
Thank you. Thank you very much for inviting me.
Yes, I'm honored to have you on the podcast. You have such an impressive bio. Being that you have been so heavily involved in thermal ablation, I just think this podcast episode is going to be very helpful to a lot of the Save Your Thyroid community. Since you are an interventional radiologist, let's get started with you telling us about your experience with interventional radiology since 2012. And for those who aren't familiar, tell us what exactly is interventional radiology?
Yes, thank you very much for this question. I fall in love with this kind of subspecialty of radiology when I was a student, because interventional radiology is a way to provide minimally invasive treatments through the guidance of radiology. Just let's think about thyroid. The ablations of the thyroid are performed under the ultrasound guidance. And there are several other techniques, or for example, ablations that can be guided in the lung, in the bone, in liver, or in kidney with the CT guidance, with MR guidance. And so we interventional radiologists perform a large variety of ablations and other procedures to treat patients. Personally, I work in an oncological hospital, so 80% of my practice is on patients with tumor. Performing ablations are kidney cancer, lung cancer, and of course, also thyroid cancer. I started in, let's say, 2012 approaching thyroid before I was already doing during my specialty ablation in different organs. And in Italy, this kind of treatment was developed, let's say, more than 20 years ago, but never spread a lot. And in that year, I found that very, very interesting because we had a lot of patients. I was doing a lot of ultrasounds and a lot of patients with nodules. I wanted to explore more this kind of treatment. And so from my side, everything started in that period.
I'd like to take a moment to thank the sponsor of this episode, Cambridge Interventional. Cambridge Interventional, a US-based company, has decades of experience in development, manufacturing, and sales of RFA and other medical devices. Radiofrequency ablation is a non-surgical, minimally invasive thermal ablation procedure used to treat various tumors, including thyroid nodules. If you have watched this channel before, you know that I personally underwent thyroid RFA treatment for a very large thyroid nodule and was able to save my thyroid and avoid surgery. If you'd like to learn more about Cambridge Interventional, please visit their website, cambridgeinterventional.com. A big thanks goes out to Cambridge Interventional for helping physicians to save thyroids and also for supporting this channel by sponsoring this episode. Now, back to the podcast. In your professional societies that you're a member of several, how did this bring out and promote thermal ablation?
Yes, I am a member of CERSI, which is the European Society of Interventional Radiology. And I have to acknowledge that at the beginning, there was not a lot of interest regarding thyroid, because interventional radiologists were more used to treat other organs and not a lot used to deal with head and neck tumors. So I started participating in other societies, the Endocrinological Society, the European Thyroid Association. And in 2018, I felt the need of having a dedicated society or group of people dedicated to the study of minimally invasive treatment applied to the thyroid. Because I realized that in Europe, there were endocrinologists, surgeons, nuclear physician, interventional radiologists, each one talking to each society or their own specialty group with a very limited interconnection. That group was founded with the main aim of having a multidisciplinary group of different people participating. And I found a lot of interest from surgeons, endocrinologists. That born as an Italian group, and now the last year it became a European group. I think we are working quite well in trying to put people together and trying to promote science, evidence, and the next step will be a training course fully dedicated to minimally invasive treatment of the thyroid.
That's really exciting. And the multidisciplinary approach is, I think, vital because maybe you've experienced this in Europe. There are fewer interventional radiologists, in my understanding, who are actually performing thyroid thermal ablation. Is that correct in Europe as well?
Yes, in Europe are not so few. There are, in regard of other specialty, probably it remains one of the most represented subspecialty, together with endocrinologists. Very few surgeons perform ablation in Europe.
Oh, really?
Yeah, surgeons are more more used to surgery, while endocrinologists start to prefer a less invasive approach. But in all the hospitals where there is already an interventional radiological department, the standard way is to send the patient to the interventional radiology department because they already have the skills. But still in several centers, there is not an interventional radiological department. And so if an endocrinologist wants to provide that kind of treatment, need to learn how to perform this kind of treatment. And so it is very inhomogeneous. One of the next step that we have to do is to try to have a more homogeneous formation for people that want to provide this kind of treatment, also and particularly for patient safety.
Yes, I think it's absolutely important that we have more physicians trained in thermal ablation. As you said, surgeons are very used to doing surgery. However, in the United States, we do have a large number of surgeons who are offering thermal ablation, and I think that's fantastic. We have predominantly surgeons and endocrinologists here in the US, a very small number of interventional radiologists. And I hope, being that you already, as an interventional radiologist, possess the skills and the experience with thermal ablation of other parts of the body, that here in the US, we'll see more of those providers getting on board with thermal ablation. So let's talk about training physicians and what opportunities are available that you're involved in Europe.
Yeah, that's a very good point. I always also teach my students in this regard that we are providing image-guided ablations. So we need to know very well the ablation devices and all the technology, but image guidance is as important as the device that we are using. It's like having a surgeon with an excellent hand, but with, let's say, a blind surgeon or a surgeon with a bad view, even if he is a great surgeon. So we need two different things here. On the one hand, we have radiologists or interventional radiologists that are very used to imaging and also to use imaging to guide ablation in other organs. On the other hand, we have specialties like endocrinologists who are by far more aware of the disease, or surgeons that might have higher experience in dealing with the anatomy of the neck or of the surgery of the neck. And at the present moment, as historically interventional radiologists didn't work a lot in the neck, we have a lot of gaps to be filled. I'm happy that a lot of surgeons are starting doing that, but I do not know how many surgeons have a good imaging experience in the use of ultrasound.
Exactly.
In Europe, not a lot of surgeons generally perform ultrasound. So what we want to do is try to provide a training that include ultrasound imaging, ultrasound anatomy, which is different from the standard anatomy, because what we see from outside might be different. We need to train also on the techniques for those people that are not aware of laser, radiofrequency, microwaves, but also, for example, to teach radiologists better the anatomy or the potential complications in the neck. So it's very intriguing because it's very different from training only one specialty in their specific field. I started mainly with my society, with the CERSI, and we will have the first European course in October, mainly dedicated to interventional radiologists, but open to any other kind of specialty, because we want, and it's easier for me, to start working on interventional society and a community. But then we are planning for February an MITT course, the Minimally Invasive Treatment of the Thyroid group, held a conference each year in February. And this year, we will have also a hands-on course that will be open to anyone, any kind of specialty, and we'll see the involvement of teachers from radiology, interventional radiology, endocrinology, and surgery. So here the point is trying to put together as many people possible to provide the best teaching with all the different point of view in order to train new specialty, regardless the specialty of origin, but with a certified training, so that each patient can know that that specific physician has been properly trained in that kind of procedure. That is something that at the moment is lacking, and it might be dangerous when a lot of physicians start a new procedure without any kind of training.
Training is vital. There's so many important structures in the neck. We don't want doctors to be in there doing things that could potentially harm patients. So these training opportunities are incredible. If you will allow me, I will share links to information about these training opportunities in the description of this video for any physicians who want to participate. Would that be okay?
Absolutely. Yes. Okay. At the moment, the October course is fully booked, but I can provide you the dates and the venue for sure. Email to be updated, also the website of the group.
So for anyone viewing this, look in the description of this video for information on the MITT conference coming up in February 2024. So thermal ablation was first used primarily for treating benign thyroid nodules, but it is now expanding to thyroid cancers in certain cases and metastatic lymph nodes. Can you explain a bit about how that is happening and where do you see this going in the future?
So we all started with benign disease, and still now it represents, let's say, 90% of cases. But it's very, very interesting, the application in patient with thyroid cancer, because we worked a lot on that and we had excellent results. In the 2021, I coordinated a group from the CERSI and together with European Thyroid Association to develop guidelines specifically designed for this application in patients with thyroid cancer. We did a lot of work, but now we have even guidelines for this specific application. Thermal ablation can be applied in a variety of patients with cancer. The key is the multidisciplinary approach. Each patient should be evaluated by different specialties, and we always have a multidisciplinary team discussing these particular cases. So endocrinologists, interventional radiologists, surgeons, and we need to reach an agreement on the best treatment for that specific patient. And thermal ablations can be proposed, for example, for the treatment of those very small thyroid cancers that are called microcarcinomas, generally less than 1 centimeter, that also patients might know that can be even followed. There is a theory and a practice of active surveillance of those kind of tumors that are so small, so indolent, that maybe they will never grow up until they will determine any kind of problem for the patient. So it is even possible to leave that there. But, and you can understand as a patient, once we diagnose a nodule, once we tell the patient that this is a tumor, it is very difficult to tell the patient not to do anything. And on the other hand, to tell the patient to remove the gland completely and undergo a major surgery that might even not be necessary is even worse for me to tell the patient, to suggest a surgery, telling the patient maybe it's not necessary. In that specific field, minimally invasive treatments, in my opinion, are the perfect option because they provide the cure of the tumor without the invasiveness of surgery, and the patient undergo ablation and after a couple of hours can go home without a big scar, without problems. Of course, this is a very specific subsetting of patients with very small tumors. And even not all that kind of tumor can be treated. There are some technical issues. So each case should be carefully evaluated. I see a lot of patients that came to me. I performed another ultrasound and found some issue. So I didn't perform finally the ablation. There are more technical, but like if it is outside the capsule, or if there are already lymph nodes or difficult locations or more technical aspects. Coming back to the training, that is very important, having physician training also in understand when it is possible, this kind of technique. And the results are impressive. All the literature at the moment tell us that the results are the same as surgery, by far less complications and less problems for the patients. Let's think about hormonal replacement with thermal ablation. That is not necessary. Of course, surgery is there by hundreds of years. We are very young, we have less numbers, but we are doing a lot of research. There is protocol, a study, a registry ongoing, where all the physicians can insert their data in order in the next year to have a large amount of data to study and to confirm the present results. So in my idea, this will be the future for the treatment, for example, of small papillary thyroid cancer, particularly instead of active surveillance. There are other subsettings where we can apply ablation, which are mainly the palliative setting. I well remember one of the first cases I treated was a quite young woman who had thyroid surgery and 3 neck dissection for lymph nodes with one single new node in the neck. And surgeon proposed for another time surgery that the patient completely refused. Absolutely. She already had a lot of problems in the movement of the neck after 3 neck dissection. And it has been the first time in my career where a surgeon came to me asking help.
Oh, wow.
And I was not considering that. I was treating benign nodules, and that surgeon asked me, "Can you do something? That you are treating thyroid, you and your colleagues." I was working with a very famous interventional radiologist in Italy, that was Professor Solviati, one of the pioneers in ablation in the liver. And so we decided to try to propose this patient. That was really a first treatment, never done before. And it was like 15 minutes, perfect ablation, no problem. The patient didn't have to undergo another surgery. And we are following her since now 11 years. Of course, are not so many that kind of patients. Again, in the multidisciplinary approach, what I tried to underline in the guideline is always to think about minimally invasive treatment. If you are a surgeon and have a particular case, you do not even know if it is feasible, but just think and just ask someone with that expertise, because in some cases it might be a very, very good option. Also, we treated some cases for palliation, recurrence, a lot of tissue in the neck, not feasible the surgery, and with ablation we achieved not the complete cure, but a significant reduction of the tumor. So the patient was better, no more symptoms, very reduced amount of tissue. And as this kind of tumor grows very slowly, with this approach it is possible to provide a lot more time to patient in good clinical condition. And the last application that a lot of physicians are not absolutely aware is that we can treat metastasis. If you have lung metastasis from the thyroid, if you have bone metastasis, liver metastasis, we can perform ablation. A lot of patients are sent to radiation therapy or systemic oncologic treatment, but again, not in all cases. But in some cases, it is possible to treat the patient with 1, 2, 3 liver metastases, for example, with ablation.
Wow.
And it is something that we tried to underline in the guidelines, because it's again a good option, I think.
So in those cases, would those be patients with different types of thyroid cancer, like medullary or anaplastic, who would have these distant metastases?
Yes, it depends really on the number of metastases and of the growth of the metastasis. Technically speaking, we call the patient that can be treated those with oligometastatic or oligoprogressive disease, because of course, if you have one lymph node in the neck, we can treat that one. If there are 50, we cannot do that.
Right.
If it is one that is slow growing, we can work on it. If you have 3 that are doubling in 15 days, it is impossible to apply this kind of technique, which is the line underlying all the local treatments, including radiation therapy. If you have a slow growing, not a lot of lesions, so oligometastatic or oligoprogressive, so local treatments are the perfect fit. But again, each case is different. And so each case, we discuss each case in the multidisciplinary report.
That is incredible. I don't think I've heard anyone talking about that in the US, about that application. Do you know if that's done anywhere outside of Europe?
Yeah, of course. The vast majority of the practice of interventional radiology and of interventional oncology is the treatment of metastatic patients, regardless the origin of the tumor. We are treating patients with liver breast metastasis, with lung sarcoma metastasis. When you have a metastasis in the lung and is one single slow growing, we can treat that locally as surgery, regardless the origin of the tumor. The point is that other physicians, for example, surgeons or oncologists dealing with colon cancer, are used to contact us and discuss the patients with us in the multidisciplinary board. So, for example, on liver is on colorectal metastasis. It is more difficult to be involved in the multidisciplinary team of people working in head and neck cancer. Mm-hmm. So that is one of the next steps. Start participating in that multidisciplinary board and to spread the awareness. That kind of treatment are already applied for other tumors. It seems incredible in 2023, but still there is a lack in information among different specialties, and sometimes it's very close. If someone is dealing with breast cancer, do not think about looking how thyroid cancer is treated. And sometimes it's just enough to talk with a colleague at the bar to discover something that is in the field from years. And this is one of the main points where it is very important what you are doing, because diffusing the information and reaching the patients with the correct information might be another way to spread the knowledge of some kind of techniques. So this is very, very important, I think.
I absolutely agree. I'm so glad we're talking about this because this is something that people need to know about. Let's talk about your role in the writing of the European guidelines for thermal ablation of thyroid nodules. Tell us about what those guidelines will influence in the practice of these procedures across Europe and the globe.
One of the main issues in the present practice of medicine is that physicians like a lot to have guidelines.
Right.
It means something written that in some way also protect them in their practice. So up until there are not guidelines, if you propose any kind of treatment to a patient, it is something on your personal experience, on the literature, but is not endorsed by any society. So we conducted a survey in Europe asking people if they were aware of thermal ablation, and 80% answered yes. And if they referred patient for thyroid ablation, and only 1/3 referred patient.
Wow.
Yes, when we asked why, they answered because there are no guidelines. So that was the primum movens to decide to write the guidelines, which is quite a hard work, but at that point was really needed. And since I wrote those guidelines, me and all other colleagues in the working group, I've been called in several conferences and meetings to discuss that, and a lot of colleagues were very happy of having a document endorsed by two of the main society of Europe specifically about this topic. So this really was a turning point. There was a before where people was doing the practice on their own knowledge of the literature or experience. And now there is something written that suggests that this kind of treatment should be evaluated in the cases of patients with thyroid cancer. Definitely. So now really it changed a lot. And it is very useful, I found, for colleagues. A lot were congratulating us for that paper because it is helpful in their practice, and they see that they are suggesting something that is endorsed by big societies. So they are really more prone to suggest the patient. They can tell the patient, go to Dr. Mauri evaluating this option. It is an option that is stated by European guidelines. Not go to Dr. Mauri because he's doing something strange. I heard about that,
Right.
but just see.
Right. You're validating the practice of thermal ablation for thyroid nodules and cancers through these guidelines. And it's so incredible that your guidelines in Europe were published in 2021, correct?
Yes.
So we just here in the US had our guidelines published like a week ago.
Yeah.
So
yes.
And
in the US, you are doing an incredible work because you are proceeding very, very quickly. It took a lot of time in Europe from the first experience back in the early 2000s to the guidelines. I hope that also having the European guidelines help the United States to speed up the process of elaborating guidelines. for the benefit of patients.
So, Dr. Mauri, you've authored 170 different publications. Let's talk about some publications that might be relevant to our conversation today.
I always liked to study what I was doing, and I loved doing research since I was a resident. So then I ended up also producing some literature. For example, one of the initial publication on the topic of thyroid was about the comparison of different techniques. You might know that a lot of people is talking about radiofrequency, but actually we have different techniques that all are called ablations. Mm-hmm. So we tend to call thermal ablation, and in the group of thermal ablation, we have different techniques. I started with laser in Italy, and then when RFA came, I also tried with RFA. Now I'm working also with microwaves, which are the new one on the field. And a lot of people were trying to compare laser and radiofrequency, each one working with one technology. What I found using the same approach, the same way of treating the patient, is that the result that I and my colleagues at the time, again, it was the group of Professor Solviati, we found exactly the same results by using laser or by using radiofrequency. What that mean? What was my interpretation of that? Was that maybe there is not only an issue regarding the energy that we are using, laser or radiofrequency, that eventually have some differences, but what is most important is the people, is the physician that is doing the procedure. Because I don't want to say I am better than other, but my results compared to myself are the same. The way to perform the ablation is even more important than the technique that we are using. Because again, it's like a surgeon that can use two different types of scalpels, but the result is more related to the experience of the surgeon than to the device that he is using. So we also then tried to have a more balanced paper comparing laser and radiofrequency in Italy in different centers, in different groups, but among physicians using more or less the same techniques. And again, we found very similar results. Maybe radiofrequency in some way can be slightly superior to laser, is slightly faster, but in the proper hand, for sure, there is not a big difference between different techniques. It is, in my opinion, by far more important the experience of the operator using that kind of technique.
I would love to know, do you think it's important for physicians who are doing one type of thermal ablation to try different techniques, or to just start with one and stick with that one and get very, very skilled with that particular technique?
I have the chance of having everything in my hospital because there are situations in other organs where one technique is better than the other. And so I can use whatever I want. My suggestion to other or people approaching this technique is to become very skilled with one device. To be very skilled with one is by far better than trying to change, looking for a better device with less experience of the operator. So I think a good operator with one technique can provide excellent results to his patients. Very recently, with the MITT group, one of the aim is to produce new evidences, put people together to have new evidences. We collected a lot of data in Italy about one of the main issues of thermal ablation, which is the long-term results, and particularly regrowth of the nodule. Because as you know, we generally are not treating completely the nodule. The aim is just to reduce its size. To avoid complication, it might even be better to undertreat the nodule, to treat not it completely, in order to avoid the heating to go outside the nodule and produce damages, rather than trying to having a more complete ablation, increasing the risk of complication. This is one of the points where the experience of the operator is very important. What we found is that at 5 years, there is still a not negligible number of patients, about 15-20%, who has a regrowth of the nodule at 5 years. And so this is one of the main topic of the present research and the future research, how to understand which are those patients that will regrow and to try to predict which patients will benefit more for ablation and which patients can deserve more than one treatment, so that we can explain a patient, you are in the group 1, it's very unlikely that you will have regrowth, or group B, where you likely will have regrowth, or you will have a probability of 20-30% of needing another treatment in the future. We are starting working on molecular sampling on the fine needle aspirations to understand if there is some easy factor that can predict regrowth. We are working on the use of contrast-enhanced ultrasound, which is also used a lot in Europe. I do not know in the United States. I don't think so. It provides the contrast for the visualization, the better visualization of the ablated area. And this also might be a way to predict the result of the treatment. So I think this is one of the next topic. Research is going step by step. It might take some years to have an answer, but hopefully we will be able to more data to provide better information to patients in the next future.
That is incredible. I think patients are going to be very interested in that data. One of the primary questions patients who are researching thermal ablation want to know is, am I going to be having a procedure that doesn't have a durable result? What we always tell them is primarily when a nodule is well treated, the risk of regrowth is very low. But there are cases when patients do have regrowth of the tissue, and it depends on that particular patient's anatomy, where their thyroid nodule is located, a whole host of other variables. So I think that having data on this topic is going to be incredibly helpful in this regard. So thank you for sharing that. I did not realize that was being done.
We are working on that. That's one of the most recent field research. And if you want, I can just mention quickly one work that might be of interest of patients, because it is exactly like a frequently asked questions from patient. It is a paper we tried to collect frequently asked questions and provide a proper scientific answer, and we published that for general practitioner.
Okay.
So like a guide for general practitioner in order to provide them the basic information on that. That is published. I think I sent that to you, and eventually might be of interest for patients if they want to look. Is a list of frequently asked questions on the topic of thermal ablation.
Definitely. I'll include the links to what we just discussed in the notes below. And regarding educating the primary care physicians, those frequently asked questions are very important, because I don't know about in Europe, but here in the US, a lot of the primary care physicians are not aware of thermal ablation. So that would be, something we might have to look into sending out to the greater primary care physician community as a tool to educate them more about these procedures. So thank you for sharing that.
What is incredible is that what we see is that often our patients that are aware of the technique that go to their general practitioner and are more informed than the general practitioner.
Right.
So I don't know if that happened also in the US.
Yes.
But that is, again, due mainly to people like you that is helping patients in achieving the information. So that's a reflection of the very good job that you are doing.
Oh, well, thank you, Dr. Mauri. I feel like patients are often just very motivated in this regard to preserve their thyroid gland and their health. The thyroid is so important to good health. If you enjoyed this episode, then stay tuned for a bonus segment with Dr. Mauri as he answers some questions from the Save Your Thyroid community. And thanks again to Cambridge Interventional for sponsoring this episode. Thanks so much for listening. Please share this content and help others. If you need resources, testimonials, and support, please join our patient community. Save your thyroid. You can also find me on social media and Substack under the media handle It's Me Jen Again. Never forget to educate yourself and be your own advocate and save your thyroid.